important to know every PSA test the patient had and to know exactly how frequently a patient is having PSA tests. We also want to know if the patient has had a recurrence. Thanks for asking all the questions. Many questions relate to, is the patient eligible? If you can only get some records for a patient but not all the records, that patient would be ineligible since we want all the records that the patient had. And if the PCP's office responds but the urologist's office will not respond, those patients are also ineligible because we need all of the records. The key question is, do you feel you are able to record all of the PSAs a patient has had after treatment? So the eligibility criteria is for evidence that medical records are available for the patient for 5 consecutive years or until distant recurrence or death, whichever is first. For patients who receive primary radical prostatectomy, the patient's urologist and primary care physician can be identified. And for patients who receive primary radiotherapy, the patient's radiation oncologist and urologist and primary care physician can be identified. The patient has at least one PSA test result within 2 years after end of primary treatment, and registrar is confident in capturing the PSA information for 2 years after the primary treatment completion. So patients will only be on your list if they received a radical prostatectomy or radiation, which includes proton beam radiation. If they have not had one of those procedures, please let us know and we will give you a new patient. If a patient was diagnosed with distant recurrence before the surveillance start date, please email specialstudy@fax.org and request a new patient. Patients receiving care at the VA are not eligible. If any eligibility question is answered no and is submitted, a new patient should automatically be added to the list once the page is refreshed. So for PSA, we're asking that you please round the results to the nearest tenth. Registrars should follow the Ford's manuals. For example, a PSA of 1.2, the registrar can enter as 0, 1, 2, or 12. Numerically, these are identical numbers and will not affect the study or data analysis. Except when a patient has a result of less than 0.03 or less than 0.01 or less than 0.02 or less than any number, please enter that result as 0 for the special study. In the sole instance, we differ from the Ford's manual, and the example is given in the instructions to specifically show this. So for scans that are clearly not related to prostate cancer or prostate cancer recurrence anywhere in the body, they do not need to be entered. If you're not sure about whether a scan should be entered, please err on the side of entering. So this is different from what was explained in the instructions manual. So we are just making updates based on the registrar's feedback. For radiation planning CT scans, enter the radiation planning CT scans as other for indication of the study. So there's been some questions about recurrence. Orchiectomy is coded as surgery treatment as other site for the study only. When the doctor indicates possible recurrence and a treatment starts, this should be considered a recurrence. The date of the recurrence should be the date of the doctor's note. So for testosterone, please enter testosterone in units of nanograms per deciliter. If there's a score of less than 20 nanograms per deciliter, please enter as 0. This is following similar instructions as PSA, which is less than any number, should be entered as 0. So in the instructions, there's slight differences between the special study instructions versus Ford's. All instructions in the special study instructions document are for the special study only. Ford's should be used for routine data collection for the NCDB. Specifically, the instructions for coding biochemical recurrence in patients who are never disease-free instructions differ from the Ford's definition and are for the special study only. We do not want you to update the NCDB with recurrence differences, and we realize that this is different from Ford's. If you find that a patient has had a recurrence by Ford's definitions and that recurrence was not previously recorded in the NCDB, please update the patient's NCDB record with that information. So we have created a patient data form, and this patient data form has been added to the study website and the Cancer Forum. This can be used to aid in data collection. We've had multiple requests for this form, so we have finally finalized it, and it should be available to you. The instructions document is still the main resource for the study. So the study deadline is at 11:59 p.m. Central Standard Time on July 24th, 2017. This is an extension from the original deadline. So there's multiple routes of communication. The main one is our special study website, and the URL is listed here. We also will be posting on the Cancer Forum, and we post the webinars in the standard resource library. We would like you to send all study-related questions to specialstudy@fax.org. Study-related questions sent to the personal fax accounts will be forwarded to the special study address, and a ticket will be created. Either send an email through the contact form of the website or the email. Please do not send both, as all the emails go to the same account. We would appreciate if you could include all fins in the communication. Emails for the special study are being sent from the specialstudy@fax.org email address through an outside server. If you have not been receiving these emails, send the following information to your IT department and ask them to put us on the whitelist. Here is a slide with all of the NCRA continuing education credit. And we've had 6 webinars so far. All are worth 1 CE each. And webinars will be every Tuesday at 11 o'clock Central Time for the remainder of this study, and you can use the same link to access and register. So questions from the previous webinars in the Cancer Forum will be included on all webinars. The frequently asked questions document will be posted on the website and the Cancer Forum and the web form. So this is just a screenshot from the website, where under the instructions and resources section, there is the frequently asked questions document. And here's the website URL again. So now we will be reviewing the frequently asked questions from previous webinars. There's been some discussions about the Gleason score versus the pattern. So what we are asking for is the pattern on the primary biopsy Gleason scores on the NCDB section. So both the score and the pattern are used and meant to describe the same thing. In the case we want primary biopsy Gleason score is 4 and the second biopsy Gleason score is 3, which total a total Gleason score of 7. So what we're looking for in this example is the 4 and 3. So what should be documented when a physician states biochemical recurrence? Please mark this as the date of the first recurrence by any method. Local, regional, and distant recurrences have specific definitions in the manual. So we've been getting questions about specific PSAs. So a PSA of 7.96, we would like you to first round to the nearest tenth. So 7.96 should be 8.0, and then you would enter 80 for the Ford's guideline. Study directions state that a normal testosterone levels are 250 to 1100. This is for nanograms per deciliter. So how should 2.69 nanograms per milliliter be coded? The units for nanograms per milliliter should be converted to nanograms per deciliter. This answer should be 269 nanograms per deciliter. If the urologist and PCP are retired, we would like you to please see if it's possible to collect records from their offices. Often physicians may have retired, but the records are still available. All NPIs are required for each provider. If the NPI on the surveillance tab is unknown, we would like you to enter 0 for no providers, 9 if they have the provider, but the NPI is completely unknown, and 7 if it's unknown whether they have this provider. So comparing what information the NCDB tab has for a patient to what the medical record contains, there's more information available in the medical record than was initially abstracted. So for these instances, please select no and fill in the most updated information. We are looking for the most current data. For recurrence, what PSA level should be used to classify a patient as having a recurrence? We are not asking registrars to interpret PSA results, so please record recurrence if clinical notes indicate recurrence and/or if the patient receives treatment for recurrence. Does the patient have recurrence if he was never disease-free after treatment? For the study purposes only, we are counting this as yes, that never disease-free has recurrence, so please record the date of first PSA test after primary treatment as the date of recurrence. For biopsies, so for biopsies or polypeptides from surveillance colonoscopies decoded, no, we are only including biopsies related to prostate cancer or prostate cancer recurrence anywhere in the body. We will be updating the instructions with these changes. So now we will be answering questions from this webinar. So if anyone has any login information or any login problems, you should try and use a lowercase letter if you have a capital in your password. And if you're still having login issues, please contact the special study email address. So if you're wondering if we should ask the PCP, urologist, and the radiation oncologist for the entire medical record or just the PSAs and scans, you should definitely try to ask for the entire medical record, but you're only required to enter what is asked for on the web form, and that can be more than just PSAs and scans. So that's why we're asking for the entire medical record. There's also parts on the web form where we're checking to fact check with the NCDB data. So if you have the entire medical record, that would be the best way to confirm what was previously entered in the NCDB to be correct.
Hi, everyone. This is Ron Chen here. We're pretty caught up on the questions from today, but I also just wanted to thank you all for not only joining the webinar, but also for all of your work on this special study. I think this really is a study that will not only help the NCDB, but also will help patients. So I wanted to give you thanks for that.
If you are not receiving any responses from the urologist's office, you may need to mark the patient as ineligible and get a replacement patient. And to do this, you would just select no to the corresponding eligibility question and click submit, and a new patient should auto-populate once you refresh the page. So we want to clarify that the surveillance period is 8 years following the end of primary treatment until the time of distant recurrence or death. If you have submitted a patient that has any mistakes and you realize that you need to make some corrections, then just let us know and we can reset the patient for you. But we would need the special study ID for that patient and just send an email to the special study email address. If your site was assigned less than 12 patients and you had to eliminate one, that's okay. We only want to collect data on eligible patients. If you find that a date of diagnosis is incorrect, please send us an email and we can get the correct information to you. The first 2 years of the surveillance period are very critical. So if you aren't able to get the first 2 years, then that patient would be ineligible. But we are hoping that you can find all of the outside records for the patient. So we need records for a patient for 5 consecutive years. It is okay if there is a lag after treatment of the first PSA. We just want you to obtain a complete set of records. It's possible that the patient did not have PSAs checked for some period of time. If you have all of the records, then that patient is still eligible. If you have to pay a company to pull the records, you're not required to pay for them. If you have to pay to retrieve the records, then you might need to mark the patient as ineligible. If you have a patient that developed a second cancer, then you are required to enter that information because if the recurrence metastasized in the lung from the prostate cancer, we are asking for that information, and you would need to enter the treatment for the new primary cancer. The patient needs to pass all 3 screening questions to be eligible. The third question is, was there at least one PSA during the first 2 years of the surveillance period? So if you have all the records and there is a PSA within the first 2 years, then the patient is eligible.
Eileen, there's a question that looks for the website where all the webinars are stored. Can you flip to that slide, please?
If we can look at the website online too here. So this is the study website, and then we have listed all of the webinars 1 through 5, and once we finish this webinar, we will post 6. So here, the webinar recordings are on the left, and the PowerPoints are on the right. So if a patient had watchful waiting after its first elevated PSA for 4 months and was abstracted, and then the 4th month they went ahead with the biopsy and diagnosed then and went on to prostatectomy, this patient is still eligible because the surveillance period would start based on the date of the prostatectomy. So please use page 3 of the instructions manual for the surveillance period definition. So if a patient had 7,020 centigrade for radiation total dose, the conversion is 70 gray. So if a patient was never disease-free by the term recurrence, we mean progression of disease or persistent disease after treatment. So if there's a patient followed by the urologist for PSAs, and in the urologist progress notes, they state that the patient has had a PSA checked at the VA. Is the patient eligible? They would be ineligible unless this one-time VA check and the urologist note reports that what the specific PSA value was. So if you're unable to get the records from a urology office, then the patient is not eligible. So if a patient has a recurrence soon after the 8-year surveillance period, should you enter the recurrence anyway? This is optional, but we will definitely take that info even if it's not required. You are only required to record biopsies that are taken during the surveillance period. You would not need to include any pre-diagnostic biopsies. So if you, there's a question on, do we still continue to collect PSAs for patients that have a biochemical recurrence if this is before the end mark of 8 years? Yes, you're supposed to record all of the PSAs until distant recurrence or 8 years, whichever occurs first. So the 5 versus 8 years, so you would need 5 years for a patient to be eligible, but once they're eligible, we are requesting 8 years of follow-up information. So if a patient has 5 years of data at your facility and doesn't come back, would they be eligible? It seems like they would still pass the 3 screening questions if you have 5 years of data on them. So there's multiple questions on, should we collect the PSAs for patients that have a biochemical recurrence before the end mark of 8 years? Yes, we are requiring that you collect all PSAs until distant recurrence or death, or until the 8 years is up. So if a PCP states that you would have to get the patient records from another hospital, this patient would still be eligible, and we would ask that you get the records from the other hospital. If a pathology report states suspicious for LVI, should you enter as unknown? That would be yes. So if you mark a case as ineligible, it should automatically replace it with a new patient once you refresh the page. If the urology group has never replied to your request for patient information, try using the letter template that we provided. This was created to help with this type of situation. If you do not know who the PCP is and you're confident that you have all the information on the patient, unfortunately, if the patient has a PCP, the PCP could have checked the PSA, unless you're able to know for sure that the PCP did not check any of the PSAs at all. A couple of weeks would be reasonable to wait for records. If you have entered all the PSAs even after distant recurrence, you do not need to delete the ones if you've entered after the distant recurrence. So eligibility questions are for 5 years of records, and then 8 years is the surveillance window. So if you only have 5 years worth of data, then you're only required to enter 5 years. But if you have up to 8 years, we would like you to enter 8 years. So if an outside department will only be able to provide with PSA and scans, but not the PCP office notes, that would still be eligible. So if a patient's PSA levels from after treatment to present are all less than 0.1, 0.2, and 0.3, the PSA levels should be recorded as 0. If anything, if there's a less than any number, it should always be recorded as 0. And that's only for the special study and not for the NCDB. So if you discovered that the surgery for prostate cancer was actually second course treatment and should not have been picked up as analytics for your facility, and they were on watchful waiting as first course treatment, we are still considering those patients as eligible. And the surveillance start date would just be the date of the prostatectomy or the end date of radiation. If you have all of the annual PSAs from the urologist chart for 8 years, do you have to contact the PCP? Yes, because the PCP may have also checked PSAs, and we need to know that. If you think that all of your patients will be ineligible, then you can send us an email instead of spending hours, days, or weeks answering no to eligibility questions, and we can let you know how many patients were eligible at your site. So just send us an email and we can let you know how many patients that you have in your pool. So if the urologist states that the patient has recurrence based on PSA level, would you consider this a local recurrence? No. Local recurrence is defined in the instructions document, and if it does not meet that definition, then do not mark it as a local recurrence. So there's a question on, are the cases ineligible if the patient never saw a medical oncologist? Medical oncologists are not part of the screening questions. Many and most patients will not have seen a medical oncologist. So if a PCP does not reply to the request for data, but you have all of the PSAs from the urologist, is the patient ineligible? That is correct. They are not eligible. You would need the PSA data from the PCPs. The term salvage radiotherapy indicates a recurrence. So please document that in the recurrence section. So if you have results from the urologist and the PCP and PSAs for 4 years, is the patient eligible? It depends if you have the complete medical record for 5 years. And if the PSAs were only taken in the first 4 years, that would still be eligible if you have documentation that no PSAs were taken in the 5th year. If you know the patient's urologist and radiation oncologist but do not know who the PCP is, then they are not eligible. If the patient does not have a PCP, they would still be eligible, but if they do have a PCP and you can't get the records, then they would be ineligible. So if the patient has a PCP, then you would need all the records or else they would be ineligible. If the patient does not have a PCP, they would still be eligible. If you have documentation from the PCP stating that the urologist is following PSAs and the PCP is not following PSAs, that case would still be eligible. So if you have the PSAs from the urologist, you would still need the PSAs from the PCP because the PCP may have checked additional PSAs. If you do not know if they have a PCP, then they would not be eligible. So if a urologist retired and you do not have access to the records, they would be ineligible. If you have patients that have both a urologist and a PCP, and all PSAs are done by the urologist, this is okay for eligibility if you have all the records from the PCP and the urologist. So if you know all the PSAs are done by the urologist and it's confirmed with the PCP, they would still be eligible. we're just here to answer questions. There haven't really been any more questions coming in, so. Okay, I think it's 12 o'clock now, so we are going to end the webinar for today. So we will see everybody next week at the same time, 11 o'clock Central. Thanks.